let's focus a little bit on the BTK inhibitor based therapy and have some discussion around that. Dr. Shadman, maybe we can start with you, and maybe you can give us sort of a summary of Ibrutinib has been around the longest. It was the initial BTK inhibitor that was available and studied. What are the data that we have available to review with Ibrutinib in the frontline setting? Who does it work for? And what are the expected responses that we see with Ibrutinib-based therapy in the frontline?
Yeah, the current era really started with Ibrutinib, as you mentioned, and as oncologists or hematologists, we are very interested in long-term data, like how effective these drugs are and also how safe they are. So we now have, for example, for the initial study, the phase 1b/2 study, the 1102 study that Ibrutinib was used in both frontline and relapse setting. We have an 8-year follow-up of that specific study that was just recently published in 2020. There are a lot of studies using Ibrutinib in combination or as monotherapy. I think to briefly mention some of the maybe take-home points from those studies is the fact that when you look at the data and at the 5-year, looking at the 7-year progression-free survival in the first-line setting, you're looking at 83%, and the median that's not reached. So this is really outstanding for a drug that has been around for that long, and there are still patients taking it, and with such a great efficacy. Of course, as you mentioned, the numbers are lower as expected in the relapse setting, but for frontline, we're really looking at an overall survival of more than 80%. And interestingly, we are also getting more information about some of the side effects of these, some of the side effects of Ibrutinib. For example, the 5-year follow-up of RESONATE-2 study, which was published last year, is telling us that most of the side effects of Ibrutinib would decline over time, with an exception of maybe hypertension. So the more we use these Ibrutinib, the side effects that may lead to drug discontinuation would basically disappear with an exception of hypertension. Also, more importantly, based on, again, long-term follow-up of RESONATE-2 study, we are seeing that the quality of response improves over time. So with the initial report of RESONATE-2, the CR rate was reported to be around 11% with 18-month follow-up, and we are now with 5-year follow-up at 30%. And that's, again, an important message. I think what I gather from these 2 studies and long-term follow-up of these 2 studies is that this is an effective drug. Ibrutinib works, and you take it longer, it actually works better, and the quality of response improves. Patients who may have issues with some of the adverse events initially, most of them will go away, or there are interventions that may help with those symptoms, with either dose reduction or supportive care. And more importantly, we're not seeing signals that, for example, some of the other malignancies are now showing up or changing the biology of disease in terms of transformation to more high-risk histology. So I think it's important to continue to have follow-up studies from those initial studies, but this is really promising. So this is our first drug that really changed the landscape, and it's very reassuring to see that it remains to be effective and also safe, meaning no new safety signals or concerns. Of course, we then had randomized study. The Alliance study was a very important study, a 3-arm study, just as a quick reminder that really targeted patients who we would consider bendamustine or rituximab type patients. And the patients either received bendamustine or rituximab, or Ibrutinib, or combination of Ibrutinib and rituximab. So really the study tried to answer 2 important questions. Number 1, Ibrutinib-based therapy versus PR, which is a very popular regimen for frontline setting, or was at the time. And also the question of whether or not adding rituximab specifically to Ibrutinib would be beneficial. Now, the study, as we know, was positive in terms of the endpoint in favor of ibrutinib-based therapy, and the primary endpoint being progression-free survival. And with a 2-year PFS, right, based on the original publication of 88%, and which is really outstanding. With the longer follow-up of those patients, sounds like this continues to be the case. And what I mean by longer follow-up, we don't have a follow-up publication, but later in the course of treatment, it sounds like the benefit of ibrutinib-based therapy was seen in both mutated and unmutated IGVH for the primary endpoint of PFS. And I think that's very important. As Dr. Burke mentioned, there is no overall survival benefit yet in favor of ibrutinib-based therapy. So if somebody really wants to go with BR, and in my opinion, there are other reasons to convince them not to do it. But from the OS standpoint, really, this study hasn't shown that ibrutinib-based therapy is better than bendamustine rituximab. Again, a very important finding from this study was that rituximab really didn't add anything to ibrutinib therapy. So ibrutinib is used as monotherapy. Now, we can talk about other CD20 monoclonal antibodies and whether or not those could be beneficial or not, and other BTK inhibitors, but specific to rituximab and ibrutinib, there's really no point of using the combination. Of course, the CLL community became a little bit concerned. There were seven sudden deaths that were reported on this study on the ibrutinib basically arms, and that kind of makes us look a little bit more closely at the other studies that use ibrutinib to see if this is something that is consistent, and we can see in other studies. So that's basically the 3 major studies that use ibrutinib for elderly and less fit population in the frontline setting.
To me, there's a couple of interesting things that really emerge from the longer term follow-up that we didn't really know, early on, okay, well, it's getting good responses, but with these sort of long-term follow-up data, you really see that, the PFS is excellent, even though we hear a lot of talk about MRD, even though the MRD rates are not high and the CR rates are not high, the progression-free survival is outstanding, so you can really feel comfortable, and your patients can feel comfortable when they start this drug, they are likely to have good control of their CLL for a long time. So that's point number 1. Point number 2 is, we talked initially when these drugs were just coming out, well, they never achieve CR. Well, actually, that's not quite true. And in fact, as you pointed out, with longer follow-up, they are achieving CR in a higher percentage of patients. And the third point that I think is really important is that the toxicities are a little higher than first reported. That is, when we first heard about AFib with ibrutinib in some of these studies, it was like that 3 to 5% range. And the grade 3 bleeding was like 2 to 3% range. And we are seeing with these longer follow-up that they're starting to sort of parallel the real world data. I mean, when I heard the 3 to 5% AFib number, I said, gosh, that seems to be lower than what I actually see in my practice. And now with the longer follow-up on these trials, it's more like 10 to 15 to 20% range of folks are getting AFib, and the actual grade 3 bleeding rate's about 10%, often in conjunction with other anticoagulants. So I think the toxicities are a little higher than we heard about, early on when these data were coming out.